Thanks, Jess. We might move on to our final presentation for session 1 then. So I'd like to invite Emily Tucker to the stage. She's going to give us an update on the recommendations for community-acquired pneumonia, one of our most used topics in adults. So Emily is an infectious diseases physician working at the Royal Adelaide and Queen Elizabeth Hospitals in South Australia. Like the other speakers today, she was a member of the expert groups as well, updating the guidelines. Thanks, Emily.
Excellent. Just a small topic before the break. So really I just wanted to walk through a couple of key areas with regards to the update of the community-acquired pneumonia adult section, so this is not covering paediatrics, and really give some guidance about some of the consensus decisions that have been come up with, as well as a couple of the key areas where there are practice changes, and talk about a couple of the key randomised control trials that have led to those practice changes. So the first step with community-acquired pneumonia is getting the diagnosis right, and that's not an easy step. And from that, then severity assessment, followed by where do you actually manage this patient. And really, it's a very challenging area. There are different clinical decision tools that are available. They have strengths and challenges, and none of them can replace clinical judgment. Basically, most international guidelines recommend the use of a clinical decision tool. The Americans' Pneumonia Severity Index, the UK guidelines, CURB 65. Earlier editions of the Therapeutic guidelines had recommendations to use SmartCop. But this is in conjunction with clinical judgment to determine where a patient's managed. These tools are only relevant for the populations for which they've been validated in, and studies in other locations have reported poorer results. It was a consensus decision of the Therapeutic Guidelines group to maintain a list of features that indicate the need for inpatient management and red flags for ICU support without recommending a specific risk score. And this is not a change from the prior edition of the guidelines, but certainly was debated. Now, this is not going to be visible to people in the audience, but really shows that there is an updated algorithm in the guideline that allows a clinician to walk through the different steps to get to the right point in management decisions. The first step being to work out whether the patient should be admitted to hospital based on clinical observations. If those don't require hospital admission, are there other factors that may drive hospital admission, such as social circumstances, functional status, ability to swallow oral therapy? Or for patients that do require hospital admission based on clinical observations, the red flags for the potential need for ICU support that would push you towards the severe management category. But also, given that community-acquired pneumonia can commonly be that last illness before a patient dies with multiple medical comorbidities, also considering the patient's goals of care and whether hospital admission and IV therapy is genuinely appropriate for that patient. Then, once you've worked out your location of care, the severity assessment, then that then guides the antimicrobial choice. Well, I've talked a lot about directed therapy. In most cases in community-acquired pneumonia, less than half of cases, a causative pathogen is not identified and the therapy is entirely empirical. For low and moderate severity community-acquired pneumonia, the target is the most common bacterial cause of community-acquired pneumonia, which is Streptococcus pneumoniae. Looking at the AURA data published in 2023, penicillin resistance in Australia remains very low. It is important to note, it might not be super easy to see there, that other agents that can be used as monotherapy, particularly for low severity community-acquired pneumonia, such as the macrolides and tetracyclines, have much higher rates of resistance to Streptococcus pneumoniae, up to 25% in some cases. So the aim is to give as targeted therapy as possible to really limit that collateral damage associated with broader spectrum antibiotic agents, but then to ensure that those at risk of less common pathogens and poorer outcomes receive adequate empirical therapy. So this version of the TG has retained a recommendation for combination therapy in both moderate and high severity community-acquired pneumonia. As has been discussed already, for moderate severity community-acquired pneumonia, benzyl penicillin and doxycycline remain the preferred therapy for patients with the absence of other identified risk factors for less common pathogens. And there is, and I'll go through it in a moment, a recommendation for oral amoxicillin for moderate severity pneumonia. With regards to the use of doxycycline, there have been a number of papers published during the course of this guideline update, particularly in some of the American journals, comparing doxycycline to macrolides and fluoroquinolones, and really it's come out with equivalent efficacy in this setting, but a much better adverse event profile, less drug interactions, and a lower rate of C. diff infection. For high severity community-acquired pneumonia, ceftriaxone plus azithromycin is a preferred therapy in the absence, again, of other risk factors, such as in the wet season in the tropics, for example. And the azithromycin is largely there in place for cover for atypical pathogens, primarily Legionella. As with a number of infectious syndromes, there's more emerging evidence around the use of early or oral-only therapy. And there was a lot of discussion about the place of this in community-acquired pneumonia. A lot of the key agents that can be given orally, such as amoxicillin, doxycycline, and macrolides, have excellent bioavailability. When you explore the evidence on this, there's not really a lot out there either for the efficacy versus parenteral therapy, but also not showing that's inferior either. There is some emerging evidence, though, that oral therapy is at least equivalent to IV therapy for patients who are hospitalised with community-acquired pneumonia. At the bottom there was a relatively recently published propensity match cohort study. It was a single centre study in the Netherlands, but they looked at patients admitted to hospital with moderate to severe community-acquired pneumonia and found no difference in mortality, ICU admission or readmission rate between patients who received oral or IV therapy. And so I think this is an area we're going to watch this space. With regards to recommendations, the American guidelines have a pretty blanket recommendation. If you come into hospital with a primary diagnosis of pneumonia, you get IV therapy. The British guidelines and a lot of the country-specific European guidelines have first-line recommendations in moderate severity pneumonia for oral therapy as first line, and the British guidelines also have an oral option for high severity pneumonia. The Therapeutic guidelines has, in the last edition, did have a recommendation for oral therapy for patients with moderate severity community-acquired pneumonia. So that in general is patients admitted to a non-critical care bed. But it was an in-text recommendation, and now there's a formal recommendation for patients admitted to hospital with community-acquired pneumonia that aren't critically unwell to have oral antibiotics if they're able to tolerate oral therapy. And really, we don't have a particular algorithm or scoring criteria or anything to tell us how to write that into a guideline as to how you select that patient. Lots of debate about the wording here, but really it comes back down to clinical judgment. And in fact, any of the guidelines that make this recommendation have that sort of that term there, given also we're dealing with such a heterogeneous population. Duration of therapy is an area where there's more and more evidence to say that we can give shorter durations of therapy in pneumonia. Most international guidelines now have a recommendation of 5 days of therapy for patients who have clinically improved, regardless of the severity of disease. In 2021, in The Lancet, a pivotal randomised controlled trial from a multi-centre randomised controlled trial from France was published, which looked at patients hospitalised with community-acquired pneumonia to a non-critical care bed. And they were randomised at day 3 if they'd met clinical stability criteria to either stopping antibiotics at day 3 or continuing with 5 more days of oral amoxiclav. What was found was there was a non-inferiority of discontinuing after 3 days when compared to 8 days of therapy. The primary outcome was clinical cure at day 15. No specific effort was made to identify a causative pathogen, as is usual practice in pneumonia, and only 12% of patients had a positive microsample. I think what was interesting is it was only small numbers, but there were patients in that 3-day group that had strep pneumobacteremia. There was a reasonable proportion of patients as well that had more severe disease. But I think it's really important to note that less than half of screened patients met the eligibility criteria. So this duration of therapy is really for patients who have rapid clinical response. So with this data, there is now a recommendation for patients with low and moderate severity community-acquired pneumonia that if they have had that rapid clinical response, which is normalisation of all their clinical observations, that a duration of as short as 3 days of therapy can be used. Otherwise, the duration recommended is 5 days of therapy. Again, that's a minimum duration. It depends on clinical stability and also whether the patient has complications of pneumonia, maybe a pathogen that requires a longer duration of therapy. Obviously, this shortened duration has impacts both for the individual but also for the healthcare systems. And then finally, I want to talk about adjuvant corticosteroids for high severity bacterial pneumonia. This is an area that has not had formal recommendations previously. In fact, for pneumonia, there has been a recommendation not to use it outside of indications where it had previously been recommended, like COPD, COVID, etc. So the Cape Cod study was published in the New England Journal of Medicine in 2023, another French multi-centre double-blinded randomised control trial that really looked at patients admitted to intensive care units with severe community-acquired pneumonia that was presumed to be bacterial, and they were randomised to either receive hydrocortisone 200 milligrams per continuous infusion within 24 hours of diagnosis or placebo. And the primary outcome in this study was 28-day all-cause mortality. What was found was that there was a clear mortality benefit at 28 days in the group that received hydrocortisone, with an absolute mortality benefit of 5.6%. Looking at secondary outcomes, there was also a significant reduction in death by any cause at 90 days. And for patients that weren't mechanically ventilated at the time of enrolment in the study, there was also a significant reduction in requirement for endotracheal intubation. One of the concerns with regards to corticosteroids are those complications associated with it, hypoglycemia, infections, etc. And there was no increased rate of either in this study. This data has been pulled into a number of different meta-analyses that have subsequently been published. This one was in CID last year and included 15 randomised control trials of just under 3,500 patients. And again, supported that there was a mortality benefit in patients who received corticosteroids in this setting, with a number needed to prevent death of 1 death of 34. What's important to recognise is the data is not there for patients outside of severe community-acquired pneumonia and the intensive care setting, and there have been studies looking at this in non-critical care beds, and a benefit has not been found there. There's also evidence gaps with regards to the type of corticosteroid and the dose. This particular meta-analysis didn't find a difference specifically to a particular regime. So there is now a formal recommendation in the therapeutic guidelines for critically unwell patients with high severity community-acquired pneumonia who require high flow oxygen or mechanical ventilation to receive hydrocortisone, pragmatically dosed at 50 milligrams QID within 24 hours of diagnosis. There are strict eligibility criteria, and as I pointed out before, there are evidence gaps. But what we are seeing is that this is now coming in as a strong recommendation in international guidelines. There was an editorial in JAMA with the authors of the IDSA ATS guidelines saying that it was now a recommended approach. This has been recently published in Critical Care Medicine, suggesting a similar approach to corticosteroids in this particular group, but not outside of it. Thank you.
Thanks so much, Emily. Does anyone have any questions on the update to the CAP in adults topic? No? So we've had a slight change of plans. We're going to take questions on the panel subgroup now before we head to afternoon tea. So I'd like to invite the panel back, and if I understand that some people had left some comments in the app online, so we might start with those first, and then if anyone else in the room has a question, just pop your hand up and we'll come round. So welcome back, panel, minus Brendan. Felicia, are you happy to kick off with that first question?
Yes. So there's two questions in the chat. Both are from John. Does John want to say his questions himself, or I can read them out? Okay, perfect. John is interested to know whether we considered a preference non-PIP-TAS prescription for Pseudomonas, given its fairly extreme and sustained impact on bowel microbe and VRE acquisition and C. diff?
Certainly, I think for the directed therapy of Pseudomonas, ceftazidime is recommended. And essentially the situations that, completely agree. Every journal club we seem to review a paper that says if you don't need to touch anaerobes, don't touch them. But I think the settings that this has been recommended is largely still the empirical recommendations, but certainly in the directed therapy of Pseudomonas, ceftazidime is recommended, cefepime is recommended, and unfortunately they're maybe not as prioritised for the dose optimisation because they weren't in Bling 3. So that's really feedback we can give to the Bling 3 authors.
Yeah. I think I asked Jason about that. I was like, are you going to do more trials? And he was like, no. But maybe he's changed his mind since.
I think it's an important point.
Yes.
It's the empiric choice, and often you do need that extra cover that piptazo offers that ceftazidime is not necessarily going to be there. So that's the challenge.
So I think my recollection is I didn't deal with a lot of pseudomonal infections, but I think, as Amy said, if it's directed therapy or if it's likely to be, if we're directing it, for example, in bronchiectasis, I think we're worried about those potential Pseudomonas. Oh, no, that's directed too. But yeah, whenever I think we're fairly sure it's Pseud, those other agents are first.
Yeah, I do think in practice, particularly for Pseudomonas in VAP, we are guilty of continuing piptaz because it's a short duration of therapy and you've started empirically. And I do often think there's opportunity to change, but that wasn't really the question. But anyway, just confessing my sins, I guess. And
yeah, I think for example, where piptaz is used, for example, with peritonitis, keeping on that intra-abdominal one, I think it's when we're concerned about Enterobacterales as well as Pseudomonas, for example, with I think cholangitis. Is that right? I don't know. I wasn't on that group, but that's an example.
Okay, thanks, guys. Well, I'll ask the second question. Given that 6-hourly dosing of 2 grams of Fluclox IV against MSSA far exceeds PKPD targets in nearly all situations, why escalate to 4-hourly? Is there actually clinical data that I'm not aware of? Or?
I don't know if there's clinical data. Oh, there's PKPD data.
Yeah, it's PKP data, and there are certainly, we're down sort of case report levels here, but yeah, it's primarily driven by the PKPD data.
Yeah. It's also been in the previous versions of the guideline, and it's recommended as the high dose therapy for the UCAST dosing tables, and remains to be seen how much longer Fluclox is recommended for MSSA bacteremia.
I don't use it in my clinical practice, but often I see some people using not often, but occasionally, therapeutic drug monitoring and using that as an argument to push the dose up higher. And we do see sometimes, for what it's worth, the drug levels being very low in people with even very frequent dosing, and that maybe is an argument to push to that high dosing. That's where UCAS is coming from.
Yeah, I guess the other. Oh, sorry.
Yeah, and it actually gets very complicated in the critically unwell with low albumin, and they actually have much higher free levels of Fluclox. So it depends how you're measuring the Fluclox as to whether you're getting a free level or a total and having to calculate a free. And then obviously being free means that it's cleared quicker as well. So it's actually very complicated in those.
There is a section on monitoring flucloxacillin in the monitoring antimicrobials topic, which you would have been involved in those discussions.
Yeah, certainly. I think the other thing about do you really need 4-hourly dosing? I guess there's a small amount of PKPD data, and there's almost very minimal concern about exceeding toxicity. So, the risk benefit made us not change it, essentially. A bit weak.
So just go back to the Pseudomonas. I've just found the Pseudomonas recommendations, and we have put ceftazidime ahead of cefepime and piptaz. Not just alphabetically, but ceftaz is given a priority as a 1 over cefepime and piptaz as 2s. So yes.
Yes, and also in the monitoring topic, it says between 15 and 50% of critically ill patients are reported to have suboptimal beta-lactam plasma concentrations. So I think that might
That's
also...
handy.
Yes. It's got a note.
Good guideline.
Yes.
That's from Bling.
So I had a question for Tim. Well, I think it was actually on your second talk rather than your first one. But you talked about aminoglycoside sparing regimes. I mean, if you're going to drop the aminoglycoside out, what would you put in? Would you go to meropenem or cefepime or?
So no, you can have it's there now in the guidelines. So you can have a look. So if you have a look at complicated diverticulitis, I haven't got it in front of me, but from memory, the options then become using ceftriaxone metronidazole as an option. I think Augmentin is there for some other indications such as cholangitis, but if it's complicated with bowel perforation, I think that's the recommendations for buptazo. Caveat, I wasn't involved in writing those sections, but they're the it's in the guidelines now for a couple of indications, and I think where the discussion is going is what other indications and what other kind of tools could we use to identify these patients that we could avoid the aminoglycoside for. And as an aside, you know, these anecdotes are helpful, but whenever I teach JMOs, I say if I come into the ED and I've got sepsis and you think it's coming from my belly, I want gentamicin on board. But if I come in not too well and I'm going to be on IVs for a while, I'm quite happy to go to that IV Augmentin or that other second option up front as well. And often I think in our guidelines we should be thinking what's good for me is good for the community as well. But with the caveat that you know, it's got to think about what the kind of the compromise there is the breadth of cover, and so are we able to be confident that patients are the ones where we can afford to be wrong in that first 24, 48 hours in terms of coverage, which I'm sure you know, but yeah, that's the long answer to your short question.
Yes, and we wanted to only include that advice where we already had advice to tell you what to do, so you weren't left in the lurch. So we were saying, like, if you feel confident that 72 hours intravenous therapy is going to be at least that long, then use ceftriaxone, here use Augmentin. So it's already in